Rebecca, would you mind telling us a little bit about where you're from, what inspired you to join physical therapy and to become a pelvic health specialist?
Sure. I'm from New Jersey, and I really was inspired, by my own story. I was born with one leg about 3 inches shorter than the other, and had a lot of surgeries when I was younger to try to lengthen my leg, if you can believe it. But it's a common procedure that's now done very differently than when I had it. And so I had a lot of issues with late stage arthritis, and I had about three surgeons who wanted to do a knee replacement. So I actually got into physical therapy quite young. Never had to do the knee replacement because I started doing, I guess, what's now considered more pelvic health therapy. I had issues with my bladder because there was some pretty considerable muscle wasting around the hip, where one of the very long screws had to go into my femur to lengthen from the top, and then also through my knee to lengthen from the bottom. So, went through, a ton of years of Pilates and yoga, physical therapy. And in undergrad, I decided this is what I wanted to do. And so, from being a personal trainer and going through that myself, it's pretty clear that physical therapy was in my future. Pelvic health therapy wasn't really until my second year of PT school that I found more of a passion for, people who experience bowel and bladder and, reproductive health impairments. So yeah, that's how I got here.
Oh, quite the short summary of your life. It sounds like there's a lot there. Thank you for that context, just like a little bit to who you are. Um, would you mind, because I know not everybody knows what pelvic health physical therapy is, so would you mind just describing a little bit more about like what that is and how that differs or is similar to just physical therapy in general?
Sure. And again, I might be coming at it from a broad viewpoint because to me, I mean, pelvic health therapy, it really defines a lot of conditions that's related to bowel, bladder, sexual health, digestive dysfunction, and things like that. But again, I came into it from a very orthopedic diagnosis, if you can imagine, that affected my bladder later on, because I had issues with strength that were really significant side to side. It took a pelvic health therapist to actually pinpoint, you have severe muscle wasting in your pelvic floor on that side that you had surgery on, and that you had all these, procedures done. And so, pelvic health therapy is a specialty within physical therapy to really determine a lot of the source of pretty chronic issues that people deal with involving their bladder function, involving their bowel health, involving sexual dysfunction, and even digestive dysfunction. But then that could be stemming from orthopedic issues or vice versa. So that's how I, really have come to embrace the field of pelvic health. However, I've started in, a very broad sense of it, through women's health physical therapy. I'm a women's health clinical specialist. So a lot of my entryway into it was actually through cancer, actually seeing my aunt go through cancer and have a lot of impairments that, most orthopedic therapists really either didn't develop the confidence or skills or knowledge to understand that, those orthopedic issues that are affecting women really deserve the same attention, So I started a program pretty early in my career where every woman or every individual after mastectomy had an automatic physical therapy visit like you would after an ACL repair, or you would after a shoulder surgery. And so how that relates to pelvic health for me now in my career is that I'm developing programs across the nation where every person after cesarean section or hysterectomy gets an automatic physical therapy visit in the hospital before they leave, like you would after a knee replacement or a hip replacement. So to me, pelvic health is, really an area that's still growing, but to me, it's an area that needs profound and significant improvement in terms of allowing there to be equitable care for anyone who has an impairment in any place in their body, especially that affects their pelvic health.
Ooh, that makes me very excited. And I can't tell you how many times I get to work with individuals who are recovering, years later after a cesarean birth or are having some type of pelvic floor dysfunction. And they say something along the lines of, I can't believe I didn't know that there was something I could do about this. Or I went to a doctor or provider and they told me it was just going to be like this for the rest of my life. And I wish I had known about this sooner. I wish I'd known about it before my birth. I wish I had known about it while I was at the hospital or at home. So I'm really grateful for the work that you're doing with that. Okay, so my next question for you is just I imagine you must be super busy. So who these days, I feel like when I say yes to something, it's kind of a heck yes, like I'm really interested in it. So I have to ask, who or what inspired you to volunteer your precious time for this interview today and this project, Sharing Stories?
Well, it was actually my wife, and it wasn't ask. It was you're doing this. And I just said, okay, just add it to my calendar, to reach out. So yeah, Jenna Segraves is my wife, and she's always on the list. She actually got me a job in the hospital back in 2020 because it was a posting for a women's health clinical specialist. And none of us had ever seen that. Both of us were just like, why would they need a women's clinical specialist in the hospital? This must be a mistake. So yeah, since then, she's always on the hunt for, hey, I think you should do this talk or you should do this interview. And I'm just like, sure. I'm, busy, always like creating the content, but in terms of like finding the avenues to get it out there, it takes a team effort.
Yeah, oh, that's beautiful. Well, I already thanked her, but I'm going to thank her again. Okay, so let's see. Next question here. I know, well, at least your wife alluded that one of your passions is addressing health disparities. So I want to ask you a little bit more about that. But before we do that, would you mind going ahead and just defining what are health disparities so that everyone who's listening can be on the same page here?
Sure. Health disparities are really any difference that results in a pretty, less desirable outcome in someone's health journey. And those differences, can range from person to person, or either the perception or the delivery of care that's given to that individual. So health disparities in a nutshell are differences in either the treatment, differences in either the perception, and differences in either what's perceived of the person themselves, or what's actually a difference that the person has that causes them to receive a less than desirable outcome of their health.
Okay, awesome. Thank you for that definition. So to follow that up, I'm sure you see many in your line of work. Could you give us one or two examples of a health disparity that you encounter most often?
Yeah, sure. So just the most recent example, as when I started to work in acute care, again, I was working as an acute care therapist in a hospital setting, seeing people within the first 24 hours of admission. And it could be admission after a surgery, after, an emergent, event that led to their admission. And so what I saw pretty immediate was that as a physical therapist, I would be consulted, say for abdominal surgeries involving like, a hernia repair or gallbladder surgery, or, again, a traumatic event could have been a rupture of a bowel and they had to have, part of their bowel removed, like via colectomy. And that was not uncommon to receive those. We would see pelvic and abdominal surgeries all the time. However, if someone chose to deliver their baby at a hospital and either the delivery itself or the labor wasn't going well, and they had to have an emergent, unexpected, major abdominal surgery, and we're talking about a C-section here, they would not have the same access to physical therapy services. And physical therapy services, in that sense, were not women specific. These were services that we would provide anyone who say didn't have a hospital bed at home, who had trouble getting in and out of a bed without a rail. So we would go over the log roll, go over incision protection, go over breathing, check their heart rate and their blood pressure to make sure they were safe after being under either general anesthesia or being recuperated for a while before they got up and walked. Those same interventions were not offered to people after cesarean section. And that was pretty immediate, still something that's, you know, a huge health disparity in the country, being that cesarean section is the most commonly performed surgery in the nation, in the United States. And yet individuals can be in the hospital 3 to 4 days, never be once offered a physical therapy visit to do all the things I mentioned before that we were doing after gallbladder surgery, which is a very, very considerably less invasive surgery. And so being, that there's a health disparity already at the treatment level, looking at outcomes, the outcomes of people, especially after cesarean section, are considerable in terms of how much compared to other surgeries and other even, a vaginal delivery, how much they are related to short-term and long-term impairments. And those impairments could vary from significant blood loss to mental health issues and to chronic pain. And so the disparities that we are facing now as a country are that among the top 10 most developed nations in the world, most highest income producing countries, we have the highest maternal mortality rate. So in terms of care delivery, my my primary example with health disparities is this. It first is starting at the treatment level, that individuals are just not provided the same care. And it's primarily because of how, uh, you know, what their entry point into the hospital was. If they came in to have a baby, that's the first, huge disparity in terms of the care that they receive.
Yeah.
And then in terms of those outcomes, even though both groups would have a major abdominal surgery, one being a cesarean section and one being, say a major open abdominal surgery for another reason, the outcomes are very different because again, where care is not offered in terms of rehabilitation, we see a lot more impairments.
Okay. Yeah, well, there are a lot of layers there. And I appreciate you offering some statistics because I think that just really magnifies the situation for folks who have never heard about it before. I'm wondering, you mentioned mortality rate. In your work, have you noticed that there are certain populations that are more, shall we say, negatively impacted by this particular health disparity than others?
Absolutely. So, at least in the United States, we do have statistics on the three main racial groups. And this is not to say that other racial groups, are purposely not included in the data. I'm actually really not sure why we don't have robust data on Native American populations, but we do have data on Hispanic populations, non-Hispanic Black populations, and white populations. But at least of those three groups, Hispanic, Black, and white, Black women face a death rate during pregnancy and into the postpartum, the first year after delivery, of about 3 to 4 times than their white counterparts. So that means that we're looking at national averages, and that's really been focused on death rates around that period, perinatal, right? And so Black women are 3 to 4 times more likely to die than their white counterparts. And just recently, at least as of 2020, the national rates for Hispanic populations have actually quite significantly increased as well. And so of the three groups, Hispanic populations have been historically the lowest. They still are, but not by very much. They're actually increasing in their death rates as well. And so in some parts of the country, because we're looking at national averages, we're seeing that those disparities are even higher. In places like New York and parts of the Eastern United States, Black women are 9 to 12 times more likely to die than their white counterparts. So yes, the disparities are pretty significant depending on the racial groups, um, but as a whole, they're increasing.
Yeah, yeah. Um, those statistics in particular really want to make me just like take a deep breath as I sit here sipping on my coffee with you. I also, so I'm going off script here. I had given you a couple heads up of questions, but I know I just met you, but I feel like you're going to roll with it well. I just was wondering, so, I'm aware of these statistics, and I am also, like I said, in the field of pelvic health physical therapy. And as I hear you mention these, as a Black woman myself, I have hopes of having a child someday. And those types of statistics, I mean, I can feel my heart racing a little bit. It gives me some anxiety. I think that next question I want to ask you is, I mean, this is really to all people who hope to have a child someday, right? But what would you say to them, as a healthcare provider, as a Black woman, as someone who's really in this field? Like, what would you say to kind of give them some hope in regards to like those statistics, and maybe something that you would like them to do if they, are seeking healthcare, to kind of like set themselves up for success and to feel like they have the most robust health team, like when they're planning a birth?
Yeah, that's a great question. It's one that I often, think about myself. My wife is white. We have these conversations all the time that if we were to both walk in and we are have started on the fertility journey, we both want to have children, we want to carry and give birth, and it's come up quite a lot in terms of just reading the statistics, me being on the ground, fighting to get programs started in hospitals where women can expect to have rehabilitation services so that they don't have to suffer in silence. And so my biggest, thing to that, my answer to your question and what someone like me, should be doing now is really building our team outside of the hospital. No one should walk into a hospital and just kind of depend on the team that's necessarily there. They should have support already established on the outside. Um, for people who don't understand what a doula does, before you even get pregnant, I would be, recommending that anyone really study what birth support options they have, what birth location options they have as well. Not all births, even though the majority, over 98% of births occur in hospital settings, not all births necessarily have to occur in a hospital setting. There are birth center options, there are home birth options, there are midwifery options versus having an obstetric provider. Most people just don't know that. So it really, to me, the answer to your question lies in education first. Be informed about your birth options before you walk into a hospital system and just say, hey, here's where I'm going to have my baby. And also be informed of your birth provider. There was a recent, push for, a bill in some states to be passed that birthing people are given all of their options at the forefront, and they're just not, when they start with a provider, they're just not given what that provider does. So that could be, say that provider does not want you to be pregnant past 41 weeks, and at that time they start to induce. Well, we know that your first birth could, extend all the way to 42 weeks. But again, if you're only seeing that one provider, that's all your provider doesn't want you to go past 41 weeks. And the next step would be to offer you an induction. So what we're really pushing for here is information first. Be informed of your birth options, be informed of your birth provider, and be informed of the support team that you can have, whether it's in the hospital or another location of your choice. And that would be in the form of a doula and in the form of a therapist who could help with rehabilitation and recovery.
Mm, yeah, I think that's a really helpful answer. Thank you, Rebecca. It also made me think about how, I've thought about some of my family members who have sought healthcare and had negative healthcare experiences, whether it be in an ER or urgent care or in their time giving birth. And I know something that gives me more comfort is um, the knowing at times when they've been able to have, like, because you mentioned kind of, you're talking about a support system like with healthcare teams, but I'm also thinking about support system like in someone's personal life and the impact, which is why another reason I'm so grateful we're doing this interview is because every time, um, you know, sorry, let me back up a couple pedals. I grew up in a predominantly white area, and the majority of my best of best friends are white women. And so those, may or may not be the people who, at the time when I hopefully go into birth and I'm headed to the hospital, you think like you want a friend to go with you or a family member to go with you. And also half of my family is white. And so what's been really impactful for me is this idea of people feeling motivated to educate themselves, which I know sometimes can have this like negative connotation. Like for someone who doesn't grow up with this awareness, I've heard this feedback from close friends. Like it feels like, for example, I've been condescending to them. Like I really need you to educate yourself on this. Like I'm insulting their knowledge. And I've just really reflected on how, it's really, to me, it's not that. It's just that I would like them to be more aware of statistics like this and the reality of this. And that, yes, this is almost 2023 and we're still dealing with this. And for the Hispanic population, as you said, at a rising rate, that it's really, I think, positively impactful to have people who are in our support system to be aware of this, to believe us when we say that it's happening, and to go into those settings with us so that they can be an ally for us. And by ally, I mean someone who advocates for us and someone who, if I was pregnant and I'm in pain, I can sit there and focus on my deep breathing and focus on regulating my nervous system, focus on relaxing my pelvic floor to decrease my risk of having an injury to my pelvic floor if I'm hoping for a vaginal birth, and have them be there to advocate for me so that I don't have to. It's not that I would be sleeping with one eye open, but the saying of like, where you're there and you feel like you can't relax because I'm so focused on everything around me and trying to protect myself. So I guess that's one thing that I was hoping for us to get out of this interview, was just to say that like, if I could pick one thing for people watching this to like, once, I don't know that I want to call it a simple thing, but one thing they could do, which is to maybe offer any person in their life that they know is going into birth, just to double check, is there anything else I can do to support you at this time? Do you have someone to go to the hospital with you? Do you have someone at home when you're going to be giving birth? Do you have someone to go with you to your first follow-up appointment, so that you have just one more person who's critically thinking in that position, so that the parent who gave birth can really like do their best to relax and focus on themselves.
I agree. And you're
Yeah.
talking about mental health in that way as
Yeah.
well. Yeah. I mean, that's super huge.
It's funny, I realized I'm pretty sure I started that off as a question for you, and then I went on my own tangent because I'm really passionate about it.
Oh, I love it.
Um,
Yeah.
yeah,
Super
I also
appropriate.
I was hoping we could just divert real quick to talk about, because I mentioned relaxing pelvic floor. And so I think that some people are aware that, pelvic floor physical therapists, I hear this from like friends or family members or patients, are like, are you that doctor that like, and then they start whispering, that helps people with their pee? Or like, so like, could I talk to you about sex? Or like, there's a lot of shame around it. So it reminds me of in middle school when like I would girls or people would say like, do you have a tampon? And just like always start whispering when you talk about anything related to like vaginal health, right? And so I was hoping, for people who have never heard of it, could you just briefly explain like, what does it mean to have like a relaxed pelvic floor, and what does it mean to have like a more contracted pelvic floor in regards to like stress, trauma, things like that?
Yeah, sure. And yeah, as a pelvic health therapist, we definitely get those questions a lot. And the way I try to explain it to people is that any muscle in your body can be either very tight, very tense, or cannot react quickly enough, right? And so your pelvic floor is no different. So when people talk about having a tight or tense pelvic floor that just doesn't relax well, especially in terms of they have to have a bowel movement, but they're constipated.
Yeah.
And they end up either pushing or bearing down or being too forceful. It's those cases that really get people thinking like, oh, okay, I can see what you're talking about. I can then talk about the muscle that should be relaxing in that way so that they could actually perform that function. And so that's how I tend to describe the pelvic floor to people. I'll use a part of their body, I'll use their hand, their fist, and I'll say, I want you to squeeze really tight. You could feel all your muscles working, you could feel them tensing up. Well, same thing in your pelvic floor. If you're tense, all the time without even, realizing it, say, um, you had a traumatic experience and you feel tension around your shoulders, you feel tension around your jaw, you might get headaches. Those same muscles that's working in that area, very similar to the muscles biologically that are controlling how relaxed you are when you do empty your bladder, or when you do empty your bowel, or when you should be relaxing for sexual activity. And so it's those conversations that they end and they start in whispers, but they end in just being just a very functional conversation, just talking about functions that have been affected probably for a really long time, because these are muscles that, one, we don't see, we don't try to understand when we're younger. When people don't explain them to us. When we're learning about either sex ed or our body, we don't really get the training and education in any sense of the our part of our education. Even at the university level, we don't learn about our pelvic floor as being another set of muscles in our body that react to the same stress and trauma as any other part of our body. And so I think that really just ends up to being a disconnect and really unfortunate, silent epidemic that we're seeing, where people have pelvic floor issues that can be stemming from, things that are within their, control to fix if they were just given the education about it.
Ooh, that gave me a couple chills as you were talking. And I can't help but think about when you say things like it starts as a whisper or like the silent epidemic. To me, it's so ironic because and I apologize, I just realized like the garbage truck is picking up our dumpster at work, so hopefully that's not too loud. But because so many times when I have the privilege of working with individuals, are sharing to me about what they're dealing with, and we're coming up with a game plan for their treatment and stuff, and we're talking about things from painful sex to inability to achieve orgasm or experience pleasure, or difficulty with bowel movements, or pelvic organ prolapse, right? But like the first thing we most often have to start with is this kind of like reconnection, re-meeting of the pelvic floor, because I feel like so much, like you said, we're usually not taught this growing up. And so most people don't know how to even sense, is my pelvic floor kind of in the fist or is it relaxed? And I love this work, educating ourselves, empowering ourselves to know our own pelvic floor better, for people of all genders and sexes, and especially when we're talking about this health disparity. I was watching the newer Jurassic Park movie recently, and ever since I've dove into this work, I can't watch like a scary movie or a movie that has like stuff jumping out at you without being like, oh, there goes my pelvic floor. But I love the discovery that really, to me, I feel like my pelvic floor is actually, it's almost like the biggest compass in my body now that I feel connected to it. It kind of gives me information. Oh, I feel uncomfortable in this situation, or like I feel really relaxed right now, or like I'm fine, I'm functioning, but this is a really stressful interaction. And I can feel some growing tightness, some growing pain in this area. Maybe I need to like up my self-care the next couple of days, kind of thing. So I guess that's all to say is like, that's because my next question for you is going to be, if we were lucky enough to have the whole world listen to this interview, which I'm gonna like really put out a prayer for like 100 views or something. I don't know. But if we were, what's like the one thing you want to leave everybody with? And the one thing that I want to leave everybody with is, I guess, to consider, at some point in the next year, if you have never been before, making an appointment with a pelvic health physical therapist. Consider it like, a lot of times people with vaginas like have wellness exams when they go to the gynecologist and stuff. Is I would love 10 years from now for that to be, I would love it for it to be now, but you know what I mean? 10 years from now, I would love for that to be similarly considered to go to a pelvic health physical therapist and just to start getting to know your pelvic floor better. And to encourage a loved one, maybe someone who's on their birth journey, to do the same thing. So microphone back to you, Rebecca. The whole world is listening to us right now. What is the last thing you want to leave everybody with?
Yeah, my biggest takeaway is for people to not treat people who are going into the hospital setting to give birth any differently than they would treat anyone else who's going into that same hospital. And by my own work, with acute care, occupational therapists and physical therapists, and teaching them to just give the same treatment that they give to all of these other populations, give that same treatment to someone who just had a baby, who just experienced nearly 9 months of just physical and mental change, and probably have another 9 months of still experiencing those changes until they can actually see, some return to normalcy, to their prior level of function. And so that's my biggest takeaway. And I'm doing that now as a professor in teaching doctor of physical therapy students exercise physiology and cardiopulmonary, and using people who have given birth or had a cesarean section as the case, so that they learn early on in their professional careers, before they're even clinicians, that this population experiences the same, concerns that we would have for another population. And that's where I really, want to focus on disparities, is that it just doesn't happen to the individual. It's happening, in our education systems, by excluding these groups of people because we've decided they're in the pelvic health category, or they're over in, the special electives, for women's health. We're actually setting a foundation of disparities by how we educate people. And so I really feel like the takeaway for anyone listening to what was said today is that if we start in our universities, and we start in our hospitals, if we don't, in our own practice, practice disparity, or practice care that's excluding groups of people, if we are more inclusive in our educational systems and in our care delivery systems, I think people will overall have a better experience, to where they don't have to develop chronic issues that I might see down the road as a pelvic health specialist. If they were given the same level of care, they might not have pelvic floor issues like chronic constipation and chronic pain, after tearing after delivery, or having issues after C-section, if they were given that same care that someone else was given who didn't have a baby.
I'm so glad you touched back on the school systems too, because I think that's impactful. I don't know off the top of my head the current statistics of how many pelvic health physical therapists there are. I think we're quite low number compared to the big span of things. And then if you start looking into the intersectionality of like pelvic health physical therapists who are people of color or who hold some type of marginalized identity, that's, unicorn level percentages, right? But when we talk about, you had mentioned the support system in healthcare, and then we talked a little bit more about support system in our personal lives. I think, as a profession, we do a really good job of trying to raise people's awareness of physical therapy and promote movement and optimal health and all these things. I get excited about the idea if our school systems for PTs and PTAs, if they could even dedicate 1 or 2 more class times to talk about these disparities and to really charge the students with, putting some of this on their shoulders too, I think that would be that many more professionals out in this world who can see someone in their lobby at their hospital or their outpatient say, hey, have you considered pelvic health physical therapy? Or do you have a plan for after you give birth to take care of yourself besides the standard 6-week, post-birth appointment? So yeah. I'm actually practicing significant restraint right now because I have so many more questions I want to ask you. But Jackie Berry, who's awesome and does so many things for ABT Washington, is always reminding me that it's important to do things in short doses and stuff. So I'm gonna pause that there. This will officially conclude our interview. Rebecca, thank you so much for your time, your energy, your perspective, your experiences. I really value, I really consider this a gift that you gave all of us today. So thank you.
Thank you for having me, Rachel. It was my pleasure.